Hi, everyone, and welcome to today's webinar. We'll be starting right at the top of the hour, so go ahead and get yourself set up. Welcome, everybody who's just joining us. We'll be starting in 2 minutes at the top of the hour. Okay, good afternoon, everybody, and welcome to today's webinar on nutrition, food insecurity, and health promotion. My name is Andrew Phillip, and I'm the Senior Director of Clinical and Population Health here at the Primary Care Development Corporation based in New York. Next slide, please. And if you're new to us, the Primary Care Development Corporation is a national nonprofit. We transform and catalyze excellence in primary care with an eye towards health equity through our advocacy for primary care and related health entities like behavioral health, through our capital investment in building primary care infrastructure, and through clinical and population health related training, consultation, and coaching. Next slide. Today's webinar is sponsored in part by SAMHSA, as well as through the SAMHSA Center of Excellence for Integrated Health Solutions. It's important to note, however, that none of the content expressed today or that we discuss is reflective of the opinions or beliefs of SAMHSA, CMHS, HHS, or any other federal entity. Next slide, please. So this is part of a larger series, and really and I'll go into different components. We're sort of moving beyond kind of that 101 introduction to integrated primary and behavioral health care, and now really focus on more advanced topics. And specifically today, we're talking about diabetes. Next slide. But before we get into that, we wanted to start out with a poll. And for the first question, actually, I'm going to ask one before this, but curious who you are. We have a lot of folks who are joining us today, both over the phone and online. And if you're online, let us know which of these is most representative of your professional area. Are you kind of more classically trained as primary care, behavioral health, nutrition? Are you part of the administration or doing some kind of behind the scenes support? Are you from our government or policy partners? Are you in the insurance world? Are you a social service or community organization or something else? And I'd encourage you to use the chat function within the Zoom platform to let us know if you're in any of the other categories, and also to chat with us throughout. So we'll go ahead and take a look at share results here. Okay, so we've got just over half of the audience is behavioral health focused, which makes sense, just 58% of you. We've got rounding up behind that is primary care. We've also got 8% of folks who are nutrition-based, which is great to see, and we're glad to have you here. So we'll go on to our next slide. So it's important, obviously we're in really unique times and difficult times, and and we're not going to necessarily spend today focusing on COVID-19, but we're curious and want to acknowledge that there's probably diversity of life, actually where you're dialing in from. So curious, are you calling in from a clinic? Are you in a non-clinical office setting? Are you working from home and things are sort of otherwise normal? Or are you maybe working from home and under some unique circumstances, like also helping care for your family or others, or something else? Also, let us know in the chat box. So we'll go ahead and take a look at your results. Okay, so pretty close actually. So 31% of you are dialed in right now from the clinic, and thank you for really being, doing the work that needs to be done, for being brave, and we are extremely grateful. 41% of folks are working from home. 21% of you are at home, but also doing a lot of other things. We know it's difficult being kind of co-teachers and doing lots of other things in the background too. So we're glad that you made it here today. We'll move on to our next slides here. So again, our focus is really on integrated care and diabetes. I've talked in today's our third part of our series, and if you've tuned in before, you know that we're doing this because there's so many opportunities and needs around diabetes for integrated care, and we're really trying to improve the value of all teams, whether or not you can build out multiple members of the team, or if it's just you or the team that you have, how can you increase the skill level and competencies of everyone on the team so that they're all operating at the maximum. Next slide, please. And so this is our Nutrition, Food Insecurity, and Health Promotion webinar. If you're dialing for the first time, you've missed our first two, but that's okay. They're archived at pcdc.org and at the SAMHSA Center of Excellence for Integrated Health Solutions, which we'll provide the link for shortly. And you can see our upcoming webinars as well. Next slide. So why are we doing this? Well, obviously we know, and I'm not going to sort of belabor the point, that folks with behavioral health conditions are disproportionately likely to also have comorbid diabetes and also worse health outcomes. And of course, on the flip side of that, people with chronic medical conditions like diabetes are also more likely to develop behavioral health needs. And there's also realistic kind of things like financial incentives that also come to play. So this is a critical topic. Next slide. There's three kind of key takeaways that we're going to hopefully impart upon you today. One is certainly understanding the role of nutrition within this integrated primary care behavioral health team. We'll also be talking about what is it that the dietitian or the nutritionist actually does on the teams, and how do they affect outcomes for people who are at risk or who have diabetes. And then that third point is, even if you don't have the ability right now to incorporate a dietitian or nutritionist into your team, are there things that you can start doing immediately today with your next patient to build in some of these skills? So with that, I just want to give you a brief example of in my background as a psychologist in primary care, go to the next slide, how this would sort of come up for me as a non-sort of nutrition professional. So the primary care physician on my team may send over a consult or a warm handoff for a patient. And it often looks something like this: a 43-year-old man who is insulin dependent, also with major depressive disorder, very elevated A1C or kind of stable lab value related to diabetes of 13.5. And the question is compliance, ? And that's all I got to go on. This may ring, if this rings true for you, echo into the chat there. And if there's other kind of cases, let us know too, so we can incorporate them in. But So let's say I meet with this individual to kind of see that if we can't get it, well, if they have everything else in place, why is their A1C still so high? Is it a compliance issue? Is it something else? In talking with this individual, I learned that they have very limited income. There's some housing instability. Most of his food is really coming from either the food pantry or from the dollar store. So his options are limited. He's eating those little kind of peanut butter crackers very often. And it's kind of a question of, okay, how do I work with what I've got? And then also, what are the guidelines around that? And why do I tend to see, fluctuations in my blood sugar first thing in the morning? And so as the behavioral health provider on the team, my thought is, okay, I can kind of work with the depression. I bet there's an influence there with diabetes. I learned that from our first webinar. I can support interventions related to nutrition, but I really need another player on the team here to help me kind of navigate some of the technical aspects of nutrition and also give me some best practices. So that is where we'll kind of leave you for today as I introduce our primary speaker today. So I am honored to introduce Alyssa Gallagher. Alyssa is a registered dietitian and a certified diabetes educator. She has both education and nutrition degrees, which is great. She works at an integrated outpatient diabetes education center, and she has almost 10 years of experience working alongside nutritionists, NPs, PAs, diabetes educators, and others to support patients with diabetes. Her passions include working as a team to support diabetes management, therapeutic carbohydrate restriction, and diabetes prevention, which we'll talk about. And she's also been recently featured on the documentary Fat Fiction, which highlights the lack of evidence to support current dietary guidelines. So we're excited to have her here, and also, again, an RD who has deep understanding of integration. So with that, I will turn it over to Alyssa. Welcome.
Hi, thank you. I'm excited to be here. I actually work in the same office as your first speaker, Dr. Amy Walters, the psychologist. So when we're not in a pandemic, we are a few doors down from each other normally. So I thought that I would focus on three main areas, three kind of different areas for my presentation. Really talking about integrating as a team. So how do we do it? What has worked? Maybe what hasn't worked? What do I actually teach patients? So if you were a fly on the wall, what are some questions I ask? What are some things I look for? And then hopefully you'll get some takeaways of how could I, or what of these areas could I incorporate in my own visits? And then I have a few slides on some resources or information that might be helpful if you don't have a dietitian or CDE available. So I am a registered dietitian and a certified diabetes educator. And I kind of put both of those hats on for this presentation. So I talk a lot about nutrition, but then I talk about some more diabetes care and management information as well. So I think we're going to do a poll. So I just kind of have an idea of what nutrition resources you have available, and then we'll get going. Oh, wow. So pretty 50-50. That's interesting. Well, that's really exciting. That's actually a lot higher than I thought. I'm really excited that you guys have access to a registered dietitian, and hopefully you like them and utilize that resource as well. Okay, so we can go on to the next slide. So these are the things I'm really going to talk about. So what does integration look like in our clinic, kind of past, present, what a day in the clinic looks like for me. I broke it down like a nutrition visit 101 and CDE visit words of wisdom. So kind of things I've picked up over the years that often get missed, even with some of our endocrinology provider visits. Just the way you ask a question is so important. So I have some tidbits there and then some resources for you. So let's go to the next slide. So I am so fortunate to be working here in my clinic. I have an endocrinologist, we have PAs, we have NPs, obviously we have medical assistants, RN, RDs. All of our educators are nurses or dietitians. We're all certified diabetes educators. We have a psychologist and a social worker. Not everybody's going to maybe be in the same building at the same time, but we have at least one of those professions in the building at all times. Our offices are literally next door to each other, so we can communicate about patients, whether they're a shared patient or a case study. And then of course we share an electronic charting system. So I'm instant messaging people in a visit all the time to get input. We don't currently offer formal shared medical appointments, but we do regularly do, we call them like warm handoffs, things like that. So the other thing that we'll do is if I have time on my schedule, then we will, put them on, and I'll be able to work with a patient. Okay, next slide. We get referrals in-house, as well as we have system physicians, so within my St. Luke's Health System, or just physicians from the community. So I see a variety of different patients, and I will have varying levels of communication, it's fair to say, with the referring providers. We may be completely blind and just have a paper referral, or I may be able to message them or use our charting system to communicate with them. I have my own full patient schedule, so I basically see patients 95% of the time. And I communicate about any shared or same-day visits with our providers on site. And we kind of come up with a game plan together. So our endocrinology providers rotate between our endocrinology office and my building. They see only diabetes patients when they are here in our building. So we'll kind of come up together, okay, what did we talk about? What do we need to focus on? How can I support your goals? And what are some things that you think I might need to know? So like I said, we have lots of different ways to communicate. We might text or call, it might be during the visit. It's really cool. We have very accessible open lines of communication. And I personally love that. It doesn't work for everybody, but I love being readily available to our providers, and I know that they see the value too. So literally, doors open, they're gonna come find me and grab me. Next slide, please. So I thought it might be helpful to highlight what we have tried in the past. Like I said, we're not formally doing shared medical appointments, but we have looked into that. I've participated in probably 3 concise methods of integration. So the first one that we did was actually I came in as the first, after the medical assistant or the nurse, the first person that patient had contact with, and I actually did the assessment. So I gathered information, I asked questions, I did a mini maybe diet recall, and came to the medical provider with, hey, this is what's going on, this is what I learned, this is what they're really up to. I didn't do any billing, and the providers felt like that was really valuable because I was able to kind of tease through and actually save them a lot of time. So not a lot of education, but this method really helped build rapport. I got so many appointments later, especially from our younger type 1 patients who might be more fearful of working with their doctor or their dietitian, didn't have the best relationship. This aspect was really building a relationship. I would see them every time they saw the provider, and I became a friendly face that they would reach out to, and actually worked really well, and they got education in that regard. The next one we had high hopes for, it just didn't work out as well as we thought that it would. We had every other hour reserved. So the educator would have their patient, and they would have an open slot. And as you can imagine, it just didn't match up always. When the provider needed us, we might not be available, then we were sitting around. So it wasn't the best time utilization, but in theory was a great idea. Again, no billing involved. And this is more how we are utilized now, is we're all integrated together. So I'm very often, hey, my door's open. Do you have a second to come meet so-and-so? I want to get them scheduled with you. And I might just say hi. Or I see you have a no-show on your schedule. Can you meet with so-and-so and just go over the insulin to carb ratio that we just instituted today? So we do a much more informal, but still kind of open door policy. Even with Amy, if our door is shut, knock, and we'd love to be introduced to the patient, just so we can enhance that relationship a little bit. Next slide. I just thought I would put a little bit about billing here. I'm not going to go into it any more than this slide, but I do work for an accredited diabetes center. So a dietitian can normally bill medical nutrition therapy codes, or MNT codes. And I also have the option to bill diabetes self-management education. So I do have two pools that I can bill from, and that allows for, especially with Medicare, Medicaid, and TRICARE patients, just more expansive availability for their insurance benefits. So dietitians can bill telehealth, and since I submitted these slides, it does have to be a video. Unlike physicians, we are not reimbursed for phone calls, which is what I'm currently in my office doing. So they do have to have a video component, but dietitians can bill and get reimbursed for telehealth, and thought that was relevant given our current situation. So I do occasionally receive a same-day referral in-house and will bill for a patient. Otherwise, when a provider pulls me in, there's no billing. Even if I sit in my office, it's usually not a formal diabetes education visit. But occasionally we will do that. But in our integration model, that's about the only way that we would bill. Most of these drive-bys, warm handoffs, whatever you want to call them, are not billed, and then we just formally schedule a visit at a future date. Next slide, please. And again, just kind of to show what we do, how we do it. Our initial visits are scheduled to include time to chart, anywhere from 75 to 90 minutes, depending on if that patient's brand new to our center, brand new to me on insulin or not on insulin. Brand new to the center on insulin would be given a larger amount of time. And 60 minutes for follow-ups and diabetes prevention appointments, again, to include charting. We offer group visits, again, when we're not in a pandemic, to our gestational diabetes patients. And we offer a 4-part diabetes self-management education class that corresponds with the Medicare allotted benefit for group education. So that's just kind of what the codes that I can bill, and then the types and duration of visits that the dietitians will offer in my clinic. And there are 3 of us in the clinic. We have multiple sites, and just this one location that I'm at, are we really as fully integrated as I mentioned today. So let's go to the next slide and then do another poll, kind of to get an idea whether you have access to a dietitian or not, but if you have any experience in offering nutrition education to your patients. Wow, you guys are mostly 60-40, 50-50 today, so that's interesting. Okay, great. So in terms of the diabetes information, AADE has recently changed the name, but I went old school today. These are the 7 areas that we focus on as a certified diabetes educator. And we kind of are assessing how are they doing in all of these areas. I mean, obviously, healthy coping affects, a lot of you as you guys are working with behavioral health, and hopefully you're here because you recognize that strong component between mental health and chronic illness. And then, of course, healthy eating as a dietitian is something that I focus on too. But when you're looking at the person, you're looking at how are they doing in these 7 areas, where are their strengths, Where are their weaknesses? What might be that quote, compliance, to go with a case study? How are these 7 areas impacting this person's ability to manage their diabetes? And yes, it is often multifactorial, but I like to start with the easiest and most accessible, so they can have some success, because as you are successful at making some of these changes, that makes you motivated to want to try more changes. Where if we start with the hardest thing and you fail, you're not going to like me, and you're not going to want to keep making some of those changes. I see some questions coming through, and I'll probably wait to answer the majority of those until the end, with some help from the moderators as well. Okay, so let's go on to the next slide. So I put a lot on here, but if you're wanting to get information out of your patients, you have to ask it really, really, really specifically, like crazy specific. I'll ask people what they had for breakfast, and then they'll go through they'll tell me that they don't eat breakfast, so then we move on. And then they tell me about their muffin and mocha and banana that they have every morning, but they don't call it breakfast. So it's silly, but little things like this, when you're trying to think like a dietitian or think like a CDE, these are really important. And the longer I work, the more amazed I am at how important it is to use your words like that. So I love to talk about when you wake up, when you go to sleep, what is your quality, duration of sleep. That's going to affect cortisol levels, that will affect insulin resistance, so that's going to affect weight gain, that's going to affect carbohydrate cravings, that's going to affect insulin resistance. Again, the verbiage, what's the first time you have anything to eat or drink besides water in the morning, instead of calling it breakfast? How much do you eat of that? So they say they have cereal in the morning compared to a baseball. A baseball is about a cup. I love to use little things like a golf ball is a couple tablespoons, a baseball is a cup, just so you can get an idea of how much. I'm always amazed at how much I can underestimate the portion size that somebody's talking about, or the opposite. Maybe I'm picturing something very different than what they're eating. What do you drink? How much? How often? Beverages. As a physician who's busy, who's got 15 seconds with this patient to talk about diabetes among the 10 other things you've got on the agenda, what you drink is the most important, because liquid sugar is dynamite. Milk, 8 ounces of milk is still 12 grams of sugar. So naturally occurring, much better than a Coke, but still sugar. Fruit juice, I don't care. It's just soda with a picture of an orange on it. It's still just a bunch of sugar. So focusing on what you drink, how much, how often, and if you want a targeted intervention as a busy physician, this would be my suggestion. So these are just some questions and some things to ask to really dive deep into what those barriers might be. Relationship with food. So do they have a history of an eating disorder or weight loss surgery? Food insecurity was mentioned, and then I'll have a slide on that next, because all of those things, their relationship with food actually really, really impacts how successful they're going to be at making a change, and then how you might want to help facilitate that change. Okay, next slide. I think we missed one, the food insecurity slide. All right. We will come back to that, I guess. I will speak a little bit to food insecurity. And there was an extra slide that maybe didn't get added on here. There we are. Okay. So I just ironically had a telephone visit right before this, and this issue came up, the history of food insecurity. So this, I think, is probably not recognized as much, but this person had significant food insecurity, went without a job, had very little access to food. And that really changed his desire and ability to make changes right now. He wasn't going to throw away understandably so, any food in his house. So he really wanted to make massive changes, but didn't want to throw it away. So, you know, working through some of that. And the issues too with, so there's a question about the current pandemic. So yeah, I mean, access to food is obviously really changing. So we're talking about more, kind of like we were talking about here, fresh versus frozen or canned, where you're spending your food dollars being really important. But that history of food insecurity, I really, really, really want to highlight, because I think that we talk so much about current food insecurity, but the history of food insecurity, when you're asking this person to not eat food, not use food as a reward, not see food as just this amazing thing, it's actually, from a psychological standpoint, so powerful. And this comes up so often. That history of food insecurity might get missed because it's not an issue that you have to fix, you know, right now. But I would really encourage you to maybe ask that, or, you know, not directly per se, but you know, just tease out some of that. Some people are very willing and forthcoming with that information. Other times you might need to ask the question a little bit more directly. Spending food dollars wisely, so purchasing meat and produce with their food stamp dollars, if they have those, or the money that they have, because you know that they can get some of those higher carb other options. If you have interns, utilize them. We had them make a budget menu from our local Walmart for $40 a week for every single thing on there, that included a grocery list and recipes that only used a microwave. So personalize some of your resources to your area. Our food banks here, we have one food bank in particular that has a cooking program, Cooking Matters, which I believe is somewhat national, or at least regional. So they sign up for cooking classes, they get a skill, and they leave with a bag of groceries. And helping them just identify which foods are carbs and which foods are not. So when they're at food pantries, food banks, shopping, they can make some of those choices a little bit more wisely. And I think it is important to ask those questions without shame and without judgment, what their access to food looks like. And also what their just kind of overall financial state looks like, especially right now. I think it's really important to be conscientious of that. Okay, next slide. Next slide, please. So going back to the nutrition visit, I think it's really important, no matter what level you're working with a patient, is to, of course, meet them where they are, right? Not what your agenda is, where you want them to be with that A1C of 13.5. Oh my gosh, right? I mean, that's so high, you know, the risk factors involved with that. But when I meet with a patient, I never have an agenda. It's where are you at? What are your goals? And how can I make sure you have realistic expectations for what your goals are, and then how far and much you're willing to work and put effort into that. From this, again, focusing on diabetes nutrition, fix the problem. The problem is insulin. The symptom is sugar. The problem is insulin. The symptom is sugar. That is so important. That's so important for us to understand as we're treating our patients. And then it's really important to get that message across to our patients as well, because that changes the paradigm, right? That changes how we address all of this. Insulin is a fat storing hormone. So insulin is going to drive fat storage. It's going to increase appetite. And I'm going to speak more about this here shortly, but it really drives a lot of behavioral issues as well. And it's physiology. People aren't broken. It's just physiology. So fix the problem, which is insulin, not the symptom, which is sugar. No matter what approach you believe in, I know nutrition gets almost religious for people. And this is an exciting and crazy and confusing time with nutrition science. Nutrition science itself, I'm sorry, is not the greatest in terms of means for study and how we gather information, but it's a pretty controversial time. So I don't care whether you are hardcore plant-based or the opposite end of that spectrum. Get your patients away from eating in moderation in the standard American diet, which the acronym is SAD, right? That's terrible. But that's really what got us into this problem in the first place. And I saw another comment about anxiety and mood disorders and medications and disease and everything. So I might butcher her name, but I think it's Georgia Eid is a psychiatrist who's really involved with that. And Allie Miller is an RD CDE who really addresses just the anti-anxiety diet. So she really talks about anxiety and diet as well. So absolutely, the standard American diet is affecting mental health, physical health, emotional health, economy, you know, everything. So get out of moderation, pick a side, right? So therapeutic carb restriction is my wheelhouse. I'm very passionate about this. There is a wealth of evidence-based information out there. So I'll spend the most time talking about this, but plant-based can be equally valuable. And again, you have to go at this from your patient's perspective, not your agenda. And there's evidence to support either one. And so just kind of steering towards one of those sides rather than moderately eating bread, moderately eating donuts, moderately eating potatoes. You have to pick a side. The high-fat, high-carb foods are a metabolic disaster. I'm probably speaking to the right crowd with this analogy here, but I say that if you try to moderately eat bread, for example, when you are metabolically broken, like my population is, or you're addicted to carbohydrates, it's like an alcoholic saying, well, I don't drink beer anymore, I only drink wine. Or a drug addict saying, I only use on Monday, Wednesday, Fridays. You would never do that. That's just ridiculous. Or, you know, telling an alcoholic, just drink a couple of beers a day so you don't go on a bender. It's ridiculous when you take that same kind of language and you put it with an addictive substance, but really carbohydrates are the same. I could use the entire presentation just to get on my little soapbox about this, but I won't. But cutting out those processed carbs and addressing food addiction, if there is any. So that really can be there, especially with history of eating disorders, history of food insecurity as well, changes the emotional intensity, really, of food. But really, going back to insulin, sugar, you eat these foods, you will spike your sugar, you will spike your insulin, and insulin drives the storage of fat. Insulin drives the craving of more carbohydrates, simplistically, there we go. How sugar affects the brain is a 5-minute TED Talk. I will show that to patients if I have time. It's great for us as practitioners to watch too. So it's How Sugar Affects the Brain, TED Talk. Just search it on Google. That's a really good one to address that food addiction side and just really, this isn't your fault. There shouldn't be guilt or shame involved in this. I'm an RD CDE. I live and breathe this, and I eat a cookie and I want to eat 50 cookies. I mean, this is just how it works. So I'm going to spend the next couple of slides talking about therapeutic carbohydrate restriction. We kind of have two modalities that we use: low carb, less than 100 grams of carbs per day; very low carb, which is recognized by the ADA, which is 20 to 50 grams of carbs daily. And therapeutic carb restriction really can be used in plant-based, in animal-based, and everything in between. So you can have a variety of eating patterns and utilize therapeutic carbohydrate restriction. Next slide, please. So I just took my bullet points that I might give a patient here. And these are the key things that might go home in my patient's nutrition education. So just the basics for low carb. So yes to the person asking about the TED Talk. That's the one I'm talking about. with a carbohydrate budget, less than 100 grams of carbs per day is low carb, and this is the most versatile. So I think everyone should be restricting their carbohydrates, really any human, but especially our patients with diabetes. But this less than 100 grams per day or 30 grams or less per meal is the best way to teach that less than 100 grams. And you can do it anywhere from the plate method. Like pick a single carbohydrate food per meal, half your plate with veggies, quarter of your plate with protein, quarter of your plate with carbs. Pick a carb. Have it be a grain, have it be a fruit, have it be dairy, have it be dessert, pick one. Use the plate method. That'll typically get them that 30 grams or less. Or you can have people reading labels, paying attention to carbohydrates a little bit more. And maybe they're avoiding grains or even whole grains. Whole grains raise blood sugar too, a lot. So whole foods, natural foods is the goal, no matter what. I love to say eat to the meter. Don't medicate as a provider. Don't medicate what they eat if you can help it, right? If you can help someone eat less of these processed foods, eat less of, whatever carbohydrate restriction level works for their body, mind and soul, work with that first. I love using the meter to be a tool because, of course, there's lots of patients who are just never going to get there, don't want to get there or can't for a plethora of reasons. But many people using this eat to the meter start restricting their carbohydrates on their own because of how they feel and what they notice with their body. So this needs to be an individualized approach, and a blood sugar meter is such a fantastic way to do that. Because what works for my body might not work for your body, their body, whatever. The meal planning tips on the right side of the screen there, you'll see for that less than 100 grams of carbs per day, I provide meal plans, food labels, all of that stuff as well. And let's go on to the next slide. So very low carb diets are defined by the ADA as 20 to 50 grams of digestible carbs per day. This is such a cool and really exciting area. I just saw a question about reconciling my mistrust in nutrition science and my belief in the evidence for therapeutic carbohydrate restriction. Fair question. So there's a great resource at the end here that we'll talk about, but this area in particular has a large body of evidence to support more than just observational or, do a food frequency questionnaire one time in a year and then associate everything about that person to what they thought they ate in the last year. If you have an interest in this area, Virta Health, VIRTA Health, they are currently working with regions in California and the VA to do therapeutic carbohydrate restriction in the reversal or remission of type 2 diabetes. And they're doing clinical trials right now. They're not double-blinded because the patient self-selected. They opted to do the diet, but they measure beta hydroxybutyrate. So they actually measure, and I'll answer a question that just popped up. It makes sense here. Beta hydroxybutyrate is a ketone. So yes, very low carbohydrate diets often produce nutritional ketosis. And so Virta Health is actually measuring nutritional ketosis or compliance, dietary compliance with a blood measure. You can't fake that, you can't just do a diet recall and say, I'm doing what you told me to do. They're measuring dietary compliance with blood levels and showing amazing results. So I hate calling it the keto diet or keto. It's so trendy, and I do call it trendy keto, but it's not like just guzzle a pint of half and half in the morning and you're going to start shedding 200 pounds. It's more simple and more complicated than that, right? It's mostly more simple. You just focus on what you eat. You eat some protein, you eat some low carb veggies, you fill up on natural fats, you avoid packaged and processed foods. It's not just about switching your lean cuisine or healthy choice low fat meal to an Atkins frozen meal and a protein shake and a diet bar that says keto on it. it's really focusing on the quality. With our type 1 patients, our clinic has opted to say 50 grams or more as the minimum of carbs for our type 1 patients and pregnant patients or nursing patients. With type 1 diabetes, there's not evidence that it's not safe. Our medical doctors just feel that there's not evidence to show that it is safe. Just can it push you closer to diabetic ketoacidosis, having ketones in your blood? They're very different, very, very different. Nutritional ketosis is safe, very natural metabolic state. Have patients with type 1 diabetes all the time that do a very low carb diet. But it is more dangerous for that person if they're not well controlled, not really engaged in their diabetes management. I love them to be on a continuous glucose monitor and be really invested in their health if they're making that choice. Other contraindications, there we go, are SGLT2 inhibitors. That in conjunction, again, that medication's not unsafe. Nutritional ketosis is not unsafe. That together can put you at risk for especially euglycemic DKA, and I have seen that clinically. Pregnant nursing, severe kidney disease. Somebody did mention kidneys. So low carb diets are not high protein diets. I think I saw, we'll come back to it, but I think I saw something about potassium. We have a meeting next week, so maybe I can get back to you on one of our biggest nephrologists here who says we just shouldn't be as restrictive with micronutrients as maybe we thought in the past. And low carb diets don't have to be high protein diets. If you have damaged kidneys, high protein is harmful. If you don't have damaged kidneys, high protein is not. Either way, therapeutically restricting carbohydrates, plant-based, animal-based, either way, it doesn't have to be, and really isn't necessarily high protein. So my contact information will be at the end of this, my email. If you can't tell, I love to just be informal and chat. It's so hard for me that I can't see you guys. And I'd love to answer questions and be a resource for you. To clarify the type 1, and for somebody that's pregnant or nursing, we suggest a minimum of 50, so not this plan, a minimum of 50 grams of carbs per day or more, because we want to keep these populations out of nutritional ketosis. And again, it's not really for evidence that it is unsafe. Just kind of cover your butt, right? I mean, there's just not evidence to say it is safe. And so I do have patients in those categories who choose to do it. Nursing particularly is pretty sketchy because you lose a lot of sugar in your breast milk. So if you're eating very, very, very low carb, there's some case studies of nursing moms without diabetes getting diabetic ketoacidosis. So you have all this information here. I want to move on to the last few slides here. So we'll go to the next slide. And the next slide is really going to be about those, I call them nutrition pearls. So key things that I have found really work for my patients, and then things that you can do. Just pick one and really focus on it. Our physicians are using a lot of time-restricted eating or intermittent fasting because it's so easy. It just don't eat. You don't have to talk about what you eat. You don't have to have money. In fact, it saves money in not eating, right? So a couple of approaches our providers focus on, and I love them all for different reasons, and I could do a whole presentation just on this. Jason Fung is a nephrologist who is a great person to look more into time-restricted eating or intermittent fasting. But really, it looks like skipping or delaying breakfast, skipping or delaying lunch with maybe a 20-40 or 24. A 5-2, you might do 2 24-hour fasts. So go dinner to dinner without eating. Works great for working professionals. You still go home and have dinner with your family. You therapeutically fast all day long. And that, again, it just, insulin sensitivity is what time-restricted eating is about. Not snacking all day long. It's about insulin sensitivity, sensitize the body to insulin. On that note, talk to your patients about physiology. So you care about fatty liver, right? You care about the cholesterol, you care about the triglycerides, you care about all of this stuff, but talk about insulin and its role in cravings and weight gain. That's what they care about. That's why for me, that's why they're in my office. And that's what's going to be really motivating. And then that will also help you reach your medical therapeutic goals as well, as if they are reducing some of these processed foods, cutting out some of their snack foods, processed carb foods, and then they'll reach their goals as well. And what you can do in your short period of time is focus on something they do often. So milk every day, they have bread every day, not something obvious like, oh, I drink soda once a week when I go out, or twice a month, or we have bingo every other Thursday. Focus on something that they do every single day, because even if it's just 16 ounces of milk, 24 grams of carbs with their breakfast, or a soda that they're drinking every single day, that change, even though it's small, it's so frequent, you'll see more therapeutic benefit there. And this is my easiest tip. Tell them to choose only one carbohydrate food per meal. What is a carb? That's the first step, right? In the handout. I've got some resources for that. What is a carb? What's not a carb? Choose only one carbohydrate food per meal. This works for any income level, any education level, but especially for people who feel overwhelmed, might not have a lot of resources, feel intimidated by restricting food. It's saying, have this one now, have that one later. So it's a budget, right? That's how I use that 30 grams or less per meal, a budget of carbohydrates. That's how the plate method can work with the budgeting, right? It's using words like, I'm choosing to eat this, choosing not to eat this, not I can or can't, or should or shouldn't eat this. It's, I can eat this food at this meal. I'm going to save this for the other meal. So those are kind of some of the top 4 things I think are really helpful. You can pick one and really focus on it and go for that. Let's go to the next slide. Perfect. So if anything, show me how you're giving your insulin. Show me how you're putting on the pen needles. Show me how you're testing your blood sugars. Depending on how often you work with patients with diabetes, you might be really surprised. Some of the things that you see, we had somebody who would dial up the pen to her dose and then dial it right back down to 0. And that was giving her insulin. So show me, are you giving it in the same spot? You have huge lumps. Well, it's not going to absorb. So you are taking the time to test your blood sugar. You have your insulin, but you're giving it into this like rubber tire around your stomach and it's not absorbing. I've actually seen that a number of times. Can I feel? Can I touch? Get a glove. Feel on their abdomen. Where are you giving your injections? Feel for those lumps. Feel for that hypertrophy, because that negates really that insulin dose. It's not going to work as well. Minimally, it'll absorb unpredictably if it is absorbing. Verbiage is important. Do you forget to take your medication? They're going to tell you no. How many times per week do you typically forget to take X? How often do you forget to take your Lantus? That's a much more open, non-judgmental way to answer that question. But I get so many more honest answers just wording it that way. How many times per week? We're assuming we all do it, right? We all forget sometimes. How many times do you forget? How many times do you use a pen needle? Not these closed-ended, but getting them to think about it. Where on your body are you giving these injections? Oh, on my stomach. Okay. Do you have the same spots, or do you go all over your whole stomach? When do you give your insulin in relation to when you sit down to eat? Right before, during, after. Get the minutes, because timing is key. I have seen countless times full percentage point reduction in A1C with timing of insulin. No change in carb counting, no change in insulin doses. Just don't give it at the end of the meal, but during the meal, give it maybe 15, even 20 minutes before, but just before. So focusing on that is really, really, really important as well. So from the diabetes medication side, these are really kind of those same tips. How can I ask this question? Because any one of these things can really affect a person's control with diabetes. And when we're talking, money and access to resources, if they're giving insulin, you want it to work. And from my standpoint, I want them on as little insulin as humanly possible to achieve that goal, and keep them metabolically safe while we're working on hopefully reducing carbohydrates as well. So let's go to the next slide. The next slide is really good resources for therapeutic carbohydrate restriction. And then we'll talk about it on the next slide when we get there, but there's also a specific therapeutic carbohydrate restriction for plant-based. Diet Doctor is my absolute favorite resource. From like a patient, I don't even know what a carb is, from medical doctors, show me the science. There's a free CME course on carb restricting. So it gives you, I think, 3 hours of continuing education and some amazing handouts come with this. It's appropriate really for any level. If you've been in the trenches of therapeutic carbohydrate restriction, you might find a lot of it as a review, but a lot of the questions that were asked, what about this type of patient? What about that type of patient? What about this circumstance? I can't recommend it enough. And they don't pay me to say that. So I love that resource, and the handouts are phenomenal. There's a shopping list, low carb food swap, simple meal planning, lots of good things. Diet Doctor also has, like they do use the dirty 4-letter word keto for very low carb, but they have, they define it for true ketogenic as even lower than I do. They have moderate and liberal low carb as well, which is less than 100 grams of carbs per day. So full spectrum resources, meal planning for patients and resources for providers. Low carb clinical guidelines are phenomenal. This is, so how do I titrate someone off of medication when they're therapeutically restricting carbs, insulin, sulfonylureas, SGLT2, etc. So that's a phenomenal resource as well. There's some books that I really like. We'll go to the next slide. These are resources for plant-based nutrition. The last one is for, it's called Ketotarian. So you want to do low carb or very low carb, but you also want to follow a plant-based approach. This is not my wheelhouse. We have some people in here who this is their expertise, like more therapeutic carbohydrate restriction using animal products is more mine. Forks Over Knives, I've heard is a great one. Mastering Diabetes, it's specific to diabetes, but Forks Over Knives has more resources available. And then, like I said, the last one is for, I want to do both. I want to do plant-based and therapeutic carbohydrate restriction. And let's go to my last slide and hopefully have some time for questions. So these are just basic diabetes handouts. I love, so Novo Nordisk is a pharmaceutical company, but they have a really great diabetes education side of things that hopefully that budget makes it through the pandemic, but they have great free to print, really beautiful basic diabetes handouts. Same with learningaboutdiabetes.org if you want something that's not associated with a company. And then I just had to put this in here because we hadn't really talked a lot about pregnancy nutrition or gestational diabetes, which is probably a quarter to a third of my professional life here. Lily Nichols is really a pioneer in this realm. So she's great to follow on social media, which is Real Food for Pregnancy and Real Food for Gestational Diabetes. And those would be 2 books I'd recommend to either you suggest to patients or if you feel like that's a gap in your knowledge as well. All right, well that's all I formally have. Hopefully we have a few minutes for questions.
Yeah, thanks, Alyssa. That was excellent. And we've had a lot of activity in the chat section. I think we'll, as we're going through the chat here, there's actually one last poll that we'll put up around what action steps people are thinking about taking. But I just wanted to highlight, as people are responding to that, a couple of things that you mentioned that I think are really handy. And some of the people in the chat have mentioned, I just feel like I don't really have a lot of tools and resources at my disposal, if this isn't my specialty area. And I think the points that you made about, asking for essentially like a diet recall, anyone can do this, right? Sitting with a patient saying, okay, if you think of the past 24 hours from when you woke up to when you fell asleep, tell me what you ate in the past 24 hours. What did you eat yesterday? And just getting a sense of what day-to-day reality is for them. And I think your point about asking about history is so critical, right? Like, what is the meaning of food to our patients? And then also just helping kind of dispel some myths and learning how to, some people in the audience mentioned also learning like label competency. And so I might ask you a few questions about that. But just getting straight into some of the questions that folks have asked. There were a lot of questions around, you mentioned, you talked a little bit about food insecurity. Obviously, we may be seeing more of that now. There's a particular example around a cost, right? So when we have a situation where pizza is more expensive than a salad, right? I think this is something that we've been dealing with for decades, food deserts. How do you help people kind of work with what they have?
Oh gosh, well, I can't help anybody find toilet paper, so that's one thing I can't help with right now. It's tough. It's Dr. Robert Lustig talks about this a lot in the problem with sugar really being the issue, and it's so cheap, and it's what's subsidized by our government. So I'm mad about that. I'm just as mad about that as anybody else is, and I can't fix that. But I think whatever their food budget is, helping coach them when and where to spend that, how to spend that. So spend that on that perishable food, spend that on that produce, because bite for bite, vegetables, proteins, and fats are more nutrient dense than carbs. Carbs are dirt cheap, and then they'll be free at the food bank. So I'm not going to be talking to them about like local grass-fed beef, right? We're going to talk about, hot dogs when they're on sale, buy them and freeze them. Frozen vegetables would be preferable to canned. I mean, even me, I've been stocking up on frozen veggies because I don't want to go to the grocery store every, week right now with everything going on. Tip, microwave those frozen veggies and then broil them for a little bit with a little bit of fat, salt, and pepper. They taste just like fresh right out of the oven. So we do talk about things like that. So how to get the most nutrient density, spending your money wisely.
Great. And and I think that's just a realistic problem that we all kind of deal with our patients and ourselves in many cases. People are asking some technical questions. I want to just get to one of them I think really rings true, particularly in behavioral health and also in primary care. Patients with diabetic neuropathy, with that foot pain, hand pain, anything that they should do differently as far as their diets?
Gosh, prevention is such the key for that.
Yeah.
But what I would say anecdotally is we've seen this probably 3 times recently in clinic compared to virtually never, is acute painful neuropathy. So when you see a patient, don't bring their blood sugars down. And that, if you want to talk about a behavioral health crisis, it's acute painful neuropathy. You feel like they're going to die. So don't bring blood sugars down too fast. So for your case study with the A1C of 13.5, they're super motivated. You're going to jump on that, but that actually can worsen neuropathy when blood sugars have been really, really, really high. So going more titrating down slowly can help prevent causing this acute painful neuropathy and can help neuropathy from worsening. But quite frankly, it really is just maintaining blood sugar control, because once that damage is done, it's done. Is the really unfortunate thing for most cases with diabetic neuropathy.
So we've got many more questions. We had a great turnout for today. There's important questions here around really cultural competency and talking about nutrition, and I think that's something that I've experienced a lot as well. Jaime, if you can advance to our next couple slides here, I just want to highlight briefly. There's other resources available through the SAMHSA Center of Excellence for Integrated Health Solutions. Folks will get these slides as well as the recording. And then if you go to our last slide here, you have our contact information for myself and also for Alyssa. Please feel free to reach out. But also there is free technical assistance available through the center to answer remaining questions. We'll be forwarding those on as well. And then we have we have 4 more episodes in our series here. So between keeping in touch with Alyssa, us here at PCDC and folks at the center, we'll work through all of the remaining questions here. Thank you, Alyssa, for taking your time today. Thank you, everyone, for attending. Alyssa, any kind of final words for the folks who have tuned in today?
No, there's so many great questions that I keep coming through, and please feel free to reach out to me if you do have any remaining questions or concerns that you would like to chat with me about. I'm happy to be a resource for you guys. But work as a team as much as you can, at whatever level that you can, because ultimately it's going to make your life easier, and then you'll get better outcomes with your patients too. So find a dietitian in your community and make a new friend.
All right. Sounds good. All right. Thanks, everyone. Thank you, Alyssa. Thank you to SAMHSA and to PCDC and our sponsors. We will see you next month.